Dr. Pereira is the medical director at Columbia University Medical Center, and he's absolutely amazing. He's phenomenal. He's taken care of me on numerous occasions. I literally wouldn't be here if it weren't for him, and saved my life on a couple occasions when I had COVID and C. diff, and is responsible for helping me get my transplant. He's phenomenal as far as I'm concerned, and he's helped us out on many occasions, giving us great info and knowledge on COVID throughout the pandemic and vaccines that were available. And he's going to speak to us tonight regarding Pemgarda and the variants that are currently taking place right now. So with that, I'm going to pass it on to Dr. Pereira. And again, thank him so much for being here and speaking to us tonight. So Dr. Pereira, please take it away.
Sure. Well, Jen, thank you so much for the introduction and for once again organizing this. It's always amazing to see that, you know, transplant recipients and candidates are just sort of working together just to help each other and to learn and sort of stay healthy. So we've done this on occasion. I think many of you remember. So Jen asked me and Ira and Glenda in the last maybe 2 months ago to update the group regarding COVID-19, our old friend, and then other viruses. I think the last time I talked maybe it was either in the spring or winter, so it's been several months. So this is what I have in mind for today. Again, big chunk will be on COVID-19, but not exclusively. So we'll talk a lot about sort of the variants, vaccines, monoclonal antibodies, treatments, and then a couple of special topics regarding long COVID and sort of this MIS-C updates. I think, you know, a lot of stuff has been on the news recently, so that's sort of interesting. And then we'll finish with some updates on the influenza vaccine and RSV vaccine recommendations. And then we're going to really end on a gloom note, on a note of gloom or doom, I should say, with Mpox. But hopefully we'll keep our spirits up. So with COVID-19, I always like to sort of give everyone an update of where we stand. I think, you know, in the spring and early summer, things were usually sort of low rates and not much concern. You know, there have been, as always, new variants coming into play and usually causing some maybe new outbreaks or not. But the overall trend has been quite good. Up until maybe midsummer or sort of, I suppose, end of June, July, where this is from the CDC data. Sort of, you can see now this is August 2024 compared to a year ago. So the percent positivity of tests has gone up throughout the summer. And actually, you know, you hear the news. The CDC doesn't give you data on actual cases of COVID because that's enormously difficult to keep track, right? People have home antigen tests and not a lot of it gets reported anymore. But people think that this could be one of the biggest summer waves that we are experiencing compared to the prior years. So it's certainly not to underestimate what's happening right now. Not entirely reflected just yet in emergency room visits. It is up a little bit compared to the previous week, but certainly not as much compared to a year ago. So in some ways, maybe more cases, but, you know, not prompting ER visits. Same with the severity, right, which are both hospitalization and deaths. Compared to a year ago, you're seeing much less, sort of much lower rate of hospitalizations compared to a year ago, as well as deaths. Although it is ticking up, and both of those are ticking up in the last month or two, but still much lower than it had been last year and the prior year. So more cases, perhaps, or likely more cases, but less severe outcomes. That's where we stand. And if you were to sort of divide it out by regions in terms of the percent positivity, it's really the Southwest that's driving, or at least it's sort of a hot spot in the last few weeks. Sort of Midwest and the South are sort of in the middle. And this is probably difficult to see, but like, you know, green, dark green and green are sort of very low rates. Yellow is somewhere in between. Orange, obviously, you know, a little bit higher. And then orange is sort of worst case scenario here. We're doing okay, I suppose. You know, it's sort of certainly not as bad as the rest of the country. So I think that so far regionally, we're doing okay. Now, this is weekly rates of hospitalizations by the season, sort of a little bit more into detail what I mentioned. And again, sort of this is the winter, and this is October. It doesn't go all the way back. You know, the CDC data can be a little bit limited when you really get a little bit more granular. But you can see that certainly since maybe June, the rate has gone up. And I guess this dotted line is sort of where they're expected to peak. So at least it won't be as bad, and certainly not as bad as the winter. But again, that's always important to know. The winter is generally worse than the summer when it comes to COVID-19, which is one of your classic respiratory viral infections, much like influenza and RSV. So we're certainly going to see sort of seasonality to it. This is a much bigger graph in terms of deaths related to COVID-19. And this is essentially the pandemic in one figure, right? Here is New York, basically in March of 2020. This was the rest of the country later in 2020, big wave in the winter, and then almost as a big wave with Omicron back at the end of 2021. And then basically once Omicron arrived in the sort of once it died down in terms of the big wave, it really has been very steady decline with sort of seasons, right? Sort of winter here, summer to 2023, and then here has been the past winter. So hopefully milder and milder. And even though we're talking about numbers are going up, sort of in terms of cases, deaths certainly have been much better. And this is sort of, again, in terms of deaths, not just cases, but deaths and the regional variability. Interestingly, you know, Florida and Texas are doing really well in terms of deaths, but the rest of the country is equally sort of okay. So there's not really a big hotspot. I suppose Puerto Rico could be one, but it's not something that there is one big epicenter where lots of people are succumbing to COVID-19. Now, the data that are really important to go over is really the variants and how the virus has or does change over time, right? Because this is actually really important and will impact a lot of the things that we will be talking about and decision making, right? So I tried to get a really good resolution photo, and Jen, I also failed in my technological skills. I'm already happy that I was able to put graphs and figures and make slides. But I couldn't get, for the life of me, to get this less blurry. But hopefully you can see. Sort of the CDC does keep track of what variants are coming and going at any moment. So this is in April, May, 2 points in May, 2 points in June, July, and then the last week of July and the first week of August. And as you can see in terms of the color differentiation, these are different variants. Some, as you can imagine, are really not an issue anymore, and others come and go. And you can see the ones that are sort of up and coming and the ones that are sort of were the big variant in April and suddenly disappear, right? So JN1 as sort of one of the FliRT, and you know, there's all of these sort of acronyms now. There's SLIP, FLIP, and FLIRT type variants. This is sort of one of the parent of the FLIRT variants. Really was a big deal in April, and since then has sort of died down and has been replaced by other variants, whether it's LB1 or KP3, which is the one that sort of, you know, we've talked more about sort of as sort of one of the major FLIRT variants. And you can see that then, you know, at some point in July, KP3 became the dominant one, but soon was replaced by this KP3.11 or 3.1.1, which is sort of, you know, a descendant of KP3. So and this is important to remember. I'm going to refer to this figure again later, but it's important to know that the current variant that's predominant is KP3.1.1. And here are the actual numbers when it comes to sort of the percentage, right? Sort of instead of the graphical representation. Here you can see as of August 3rd, nearly 28% of all the variants detected or studied were KP3.1.1. And then, you know, KP3 is the second one, and then LB1 the third, and then so forth. So these are the important ones to keep in mind. as we talked about vaccines and as we talked about monoclonal antibodies. But, you know, it's obviously good to know how there's basically, if there's one important variant, it often gets replaced within a few months. You know, they only last 2, 3 months, and then something new happens. But there are different catalysts for that to happen, whether vaccines or I suppose monoclonal antibodies can sort of cause a push, or people acquiring immunity to that prior variant by just getting infected and then no longer being susceptible to to that particular variant. It's obviously a complex sort of relationship between these and people's immune systems. That's the country as a whole. This is New York and the region, which is New Jersey, New York, Puerto Rico, and Virgin Islands. Don't ask me why Virgin Islands and Puerto Rico are included in this particular region. I don't know. Uh, it's someone at the CDC decided to do that. But the interesting thing about our region, which, you know, sometimes does predict what's to come in the rest of the country, and sometimes not. You know, it's really interesting what happens. But here, if you remember, JN1 was sort of an important variant in April, and it was still so in New York around that time. But LB1 seems to have been a more important variant here in this region as opposed to the rest of the country. But, you know, unfortunately, KP3 1.1 has also become the dominant variant here in the last month or so. So not too different, sometimes sort of some small differences, but at the end of the day, these are really national trends, not just regional trends. In New York City, you know, so the New York City Department of Health also maintains data specific to the city. And it's in many ways also reflective of what's happening in the country. On the left, these are cases. So they somehow have a little bit more confidence in the cases. And a lot of it is estimation, right? Like, so patients getting, go to CityMD, for example, and have a positive PCR, they can sort of normalize those positive tests and predict for the whole city in terms of the number of the cases. But by any means, you know, it's probably an underestimation because, again, home kits are not included in these sort of calculations. But cases in the summer did go up, and since mid-July, they have gone down as well. And trending usually about a week or two after cases is hospitalizations. They did go up as well, but you know, but now going down. So maybe in the city it's a little bit better than in the rest of the country, but not by much. But certainly the same trend, up in the summer, maybe going down at this point. We talked a lot about these variants and these acronyms, right? So FLIP, SLIP, and FLIRT. So it all, you know, and this is not to sort of get too into the weeds with this, but it's sort of, you see that in the news articles. You know, what does that mean? Basically, what they came up with these little acronyms is sort of families of variants and subvariants and how they relate and where they're coming from. Now, there are additional explanations of what that means. It's like, you know, a particular amino acid, L gets replaced by F or S, and there's all sorts of technical explanations that people came up with just to come up with these cute acronyms. But at the end of the day, XBB1 was the predominant variant a year ago. And what's important about it is the vaccine that we all got in the fall, the current monovalent formulation, right? The 2023, 2024 is based on XBB. And it did serve some purpose in terms of, you know, sort of those sort of flip subvariants, and XBB subvariants sort of not being sort of as active against those who are vaccinated. And essentially that's the end of the story regarding that. But what happened was an earlier lineage of BA2, which was present almost like 16 months ago. I remember talking about BA1 and BA2 a while back. Basically, it split early on, and sort of this BA286 then created JN1, which was an important variant in early spring, which, you know, somehow then created the sort of the SLIP subvariants, which then the FliRT variants came from. And these are all small mutations that just let the lab scientists come up with these names. What's important is that the FliRT variants are the ones that are predominant now. So KP2 was an important one a little bit earlier in the summer or late spring, and then gave rise to KP3, which is obviously one that we've been talking about, and LB1. Now, KP3, what's not in here in this graph is KP3 then led to KP3 1.1. And what they're talking about here is sort of what are the differences between these variants, right? So this article that sort of just have this nice graph with, sort of the changes in the variants up until May 2004. What they talk about is what, you are going to hear a lot from healthcare authorities, and basically, which is supported by the data, that these new variants, they suggest sort of maybe a higher viral fitness, meaning the virus is more infectious in some ways. But essentially, they're not more virulent. They sort of cause the same level of disease. They're just trying to overcome some of the immune protections that people are creating, whether it's through the vaccine. In this case, for example, XBB, right? So the vaccine put an end to this lineage, basically, and a natural immunity, right? So every time sort of there is a little bit of a surge and people create some sort of immunity to JN1, well, guess what? There's a couple of other mutations down the line that then sort of overcome what we kind of developed from natural infections. So that's sort of these variants in a nutshell. But the bottom line is that nobody thinks that what we have currently is more virulent than was before. Again, there's always a preoccupation with that. There's no guarantee that future mutations will be equally as sort of, not as bad, right? Because the virus is doing what the virus can do. And there's no, it certainly is well within its possibilities of somehow mutating into something really bad and virulent. But luckily, that's not going to happen, and it hasn't happened yet. But moving on to vaccines, because this is important. And again, the vaccine that we currently have, or will have until probably a month from now, right? Like sort of the 23-24 vaccine was based on the JN or XBB1 variant, which is no longer there, right? But the recommendations overall are still the same, and this is what currently we have from the CDC. And I know that sort of, I don't know anyone who is not vaccinated, but I suppose we have to have those recommendations for adults. If you were unvaccinated as of today, the recommendation, and this is for immunocompromised individuals, by the way, the graph or the figures for adults who are not immunocompromised and children becomes impossible to go over and people maintain their sanity. So I'm just focusing on immunocompromised individuals. And because of that, that's why you will see here, it's 3 doses of either the Moderna or the Pfizer vaccines as sort of your initial vaccination, 2 doses of the Novavax. For those who have been previously vaccinated, I think the goal is to get to at least 3 doses, if not more, right? I mean, it's sort of a little bit of a low bar, but if you only had 1 dose of any Moderna, well, get 2 doses. Same with if you had 2 doses, get 1, and so forth. So this part is not that complicated. If you have had you've had your full vaccination, and many of you have, I know that that's absolutely true. Many of our transplant recipients have had 4, 5, 6, many more vaccines because of boosters and so forth. Here, basically, the minimum threshold for anyone to feel like they're up to date with their vaccines is about 4 doses, okay, of any of the sort of mRNA vaccines, whether it's the Moderna or the Pfizer, and at least 3 doses of the Novavax. But not many people get the Novavax vaccine, so we don't really have to worry too much about that. That's sort of the recommendations for vaccines. Now, booster recommendations is sort of an additional set. And basically, the CDC has been very unclear or a little bit sort of opaque about their booster recommendations since last year. Many of you remember we talked about this with the 23-24 vaccine. This is exactly the language that they have, and this is the language that they've had now for the last 10 months or so. Yeah, maybe 9 months or so, that people who are moderately or severely immunocompromised may get additional doses of the updated COVID vaccine. So basically what they recommended is everybody should get a booster dose in the fall, right? Like, so most people got that booster dose. But if you're immunocompromised, you could opt for an additional dose at some point. They didn't give a timing. If you remember, it was kind of infuriating for most of us. Well, is it 2 weeks later? Is it 2 months? Is it 3 or 4? They didn't say. They didn't have the data to say it. So basically, it was left for clinical judgment, a discussion between the physician and the patient, and often just sort of individuals making their own decisions. Now, what's interesting is for those who are 65 years of age and older, immunocompromised or not, they were a little bit more specific about that recommendation. What they said is that those individuals should get an additional, after they got boosted in the fall, they should get an additional dose at least 4 months after the previous dose. So if you got something, say you're not immunocompromised and you got a vaccine, a booster vaccine in October of 2023, the recommendations were for you to get a booster dose somewhere in February or March. So they're a lot more specific. And at the end of the day, a lot of us in transplant use that same recommendation for our transplant recipients, just extrapolating, whatever was leading them to make that decision. It was potentially applicable to transplant patients. Now, not everybody did that. Certainly some people did a month later or 6 weeks later, and that's probably okay as well. But that's the language that we've had. So what we're really hopeful is that they will come up with a little bit more specific language this coming fall, and will help us sort of figure out, how many booster doses should individuals get and the timing in between. Now, obviously, there will be a vaccine coming this fall. This was decided at some point in the spring. And it was interesting is so usually that's the usual meeting that the FDA and the CDC have to talk about the upcoming influenza vaccine. So they're always use the spring to take stock of what's happening in the Southern Hemisphere and predict what will be useful to give to people in the winter here, right, or fall. So they're sort of doubling up that meeting and also including COVID-19 sort of recommendations. So basically, but there are pitfalls with that, right? So whereas influenza has a very specific pattern that the virus, bounces back and forth between the hemispheres, right? Southern and northern hemisphere, with obviously some changes. For COVID, it's not clear that that's happening. It's not sort of traveling the world and back. The mutations are happening everywhere. So in some ways, those mutations are happening at a much faster clip for COVID. So making a decision for a vaccine in April or May is sort of tricky for COVID, because you're now sort of predicting what's going to happen 6 months down the line, and there's a good chance you can be wrong. So here's the case in point. So when they met at some point, it says June 5th, but I think it's sort of early June or at some point in May. The FDA recommended that the vaccines should be against JN1. So if you're going to make a COVID vaccine for the fall, make it against JN1. And what happened was, if you remember that the graph, a few weeks later, JN1 was disappearing, and sort of the other FliRT subvariants, KP2 and KP3, were taking off. So they had to go back to Pfizer, Moderna, and Novavax and said, we were just kidding. Make it against KP2 and KP3. Don't make it against JN1. That certainly was a little controversial. But obviously, like with the mRNA vaccines, you're able to actually change very easily, right? Like you in a weekend, you can change the formulation of the vaccine and just start producing the new version. For Novavax, it's not so simple because they're a protein-based vaccine. So it's sort of a much slower process of vaccine development. So unfortunately, Novavax is going to be JN1, and Moderna and Pfizer are going to be KP2 and KP3. Interesting twist, I mean, at the end of the day, nobody really knows which vaccine is going to be better, but there's certainly a little bit of a difference. So here are the full recommendations are actually going to be released at the end of the month. It will be in a document that I actually will disseminate through the American Journal of Transplantation. But essentially, nobody should be surprised at the language, right? That they are going to strongly recommend the 24-25 updated vaccine. But they're probably not going to say which one is preferable, right? Whether it's the Moderna, Novavax, or Pfizer. I think that sort of, they're probably going to wait a little bit more data before, but it will be interesting if one of them comes up on top. Okay, but we should all be expected a full recommendation with some more detailed information coming up in the next month or so. So, I guess the question that has been given that there is a wave happening this summer, and many of you have asked that question, should you get a booster now? Are you at risk of getting COVID, and shouldn't you optimize everything that you can for protection, right? So, I think that's a really tough question to answer right now. So should transplant patients get a booster? And I think that the answer that I've been giving my patients is it really depends. I think if you feel like you're going to be safe for the next month or 6 weeks, try to hold off and wait for the 24-25 formulation, right? It's more updated, it's going to be more protective. And the reason being is, we don't know what kind of time frame they're going to say that one needs to wait between the booster dose. So say you get a current booster right now, and then they say, wow, you need to wait 4 months for the next booster. Well, you just locked yourself out until December, right? So I think that this is sort of a little bit of the uncertainty that we are all experiencing right now regarding what to do about boosters. So I've been a little bit agnostic and just sort of having a little bit of conversation. But the depends really is about, well, if you're going to go to an event, or if you really feel like your risk is highest coming up, right? Like you're going to go on a big trip. It's obviously August, people are traveling and their weddings and things like that. Well, I mean, is it worth just getting a booster vac dose just to sort of get that incremental help, so that you don't get as sick and so forth? So I don't know. It's sort of a discussion. It's tough to say right now. I think it's going to be a much easier discussion once the vaccine is rolled out. And they really think it's going to be available in September. So we're not too far from it, right? Like we're several weeks away from sort of being able to do this. And obviously, if you think that your risk is high right now, wear a mask, take additional precautions. I think that's the bottom line until we have an additional vaccine. I don't have data here before we get to monoclonal antibodies. I don't have data in terms of people's response to the vaccines. I didn't sort of include that here today. We've talked about it before. Here are my 2 cents that I think many of you have heard, right? Immune-compromised patients, particular solid organ transplant recipients, will have a lower response rate to the vaccine than someone who has an intact immune system. That has always been the case with other vaccines, and it became really apparent with COVID-19 vaccines. But there is still benefit, and we have seen that with each formulation of vaccine, there's always sort of a paper or many papers showing that those who got the latest vaccine and are up to date, even if they did not respond fully to the vaccine, there was still a level of protection, whether it's sort of disease severity or long COVID or other sort of problems. But those are the most important ones. It sort of consistently shows that even if you're immunocompromised, taking the vaccine is an enormously helpful initiative. So, and there's two arms to the immune system. There's sort of the antibody immune system, right? Like sort of we form antibodies against viruses, bacteria, fungi, any kind of pathogen. It's an important element in protecting you. Every pathogen will have its different sort of susceptibility to the antibodies that we create. But antibodies are important for COVID. They're not sort of the only thing, and certainly they're probably not sufficient to protect you, but they are important. But there's also this whole other arm of the immune system, the T cells, or the cellular immunity part, sort of T cells, NK cells, and other components. They're just as important and that much harder to measure, right? Like we're measuring antibodies initially on a number of patients and trying to make clinical decisions based on that, but really aware that it's an incomplete picture. And there are many people who don't have antibodies, but are well protected against COVID because they have T cells, and vice versa. So that's just an important conceptual element that we shouldn't get caught up in just measuring antibodies. But with that in mind, antibodies are important. And, we've had a number of products, as you remember, of these monoclonal antibodies that have been used both to treat COVID and to try to prevent or attenuate COVID, right? So for treatment, unfortunately, we don't have one that's available right now. We had several earlier in the pandemic, and they were incredibly useful. They were so good to use because they didn't have the same issues as the antivirals do. And we'll go over that in a little bit in detail later. It's sort of a very well tolerated and very sort of effective intervention for our patients. And it just felt really amazing that you can give antibodies and someone would feel better. But also for prevention or attenuation was an amazing sort of thing. Many of you got Evusheld, right, which was also shown to protect patients from sort of severe COVID-19. But unfortunately, Evusheld, with the mutations, was taken off the market because it was not active against variants. So we've been in a state now until April without any monoclonal antibodies in the market. But what happened was that, as many of you know, in April, this particular long-acting monoclonal antibody, Pemgarda, was authorized by the FDA for use, much like in the way that Evusheld had been. So this was actually a very interesting development. In some ways, came out of the blue, quite honestly, because there was not a lot of talk about using monoclonal antibodies. Basically, it's very expensive to develop. And because the virus is constantly mutating, people, it's unclear how long it will stay useful. But anyways, regarding Pemgarda, right, the study that led to that authorization is a study called Canopy, which was designed for the prevention of COVID-19 with this particular product in adults with immunocompromised system. So it was a phase 3 open label study, so people knew exactly what they were getting. And it was looking at protection against symptomatic COVID-19. But so there was that part, the symptomatic, but also there was sort of this concept of immunobridging. Basically, you could look in vitro at the antibodies that are circulating and know how effective it is against a particular viral strain. And based on that, you can predict how protective it is actually going to be in people. And the FDA has done that. Previously, it never accepted that kind of data because it's sort of indirect data. But it accepted that to sort of expedite, approvals and authorizations of these studies. Otherwise, it would take years for this to be approved. At any rate, so here are the cohorts, right? So they had cohort A that just got the product at days 1 and 90. So there's sort of a 3-month redosing. And then in this cohort, and this was sort of, half the group got placebo on day 1 and 90, and the other half got Pemgarda. And the cohort A, which was just the people who sort of just got this, they were actually looking at just their antibody titers and comparing it against the variant JN1. And this is sort of the immunobridging concept. Now, this was the composition of the groups, right, in terms of gender, race, ethnicity, and then the reason for the immunocompromise. So what's important here is that about 11% of these patients were solid organ transplant recipients. There was a bunch who had some sort of leukemia or heme malignancy, and others were just on high-dose corticosteroids, whether it's because of rheumatoid arthritis and so forth, right? So that's sort of the patient population. Now, what they were able to show is that the titers for Pemgarda against JN1 were consistent over 3 months, and they were actually highly active in vitro studies. And actually, in terms of symptomatic COVID-19, and this was last winter, those who got Pemgarda were much better than those who did not. So whereas in cohort A, the rate of symptomatic COVID-19 was 1%, in cohort B, actually, it was 0.3%. in both arms, basically, a few people who got pemivibart got any symptoms, whereas in placebo arm, 8 people, so 5%, got symptomatic COVID. Now, the full data has not been released, so there's no paper to quote or cite and to really look into this detail. But, this was enough for the FDA to say, okay, we're convinced, here's the emergency use authorization for pemivibart in March of 2024. This was authorized, again, for pre-exposure prophylaxis, right? So if someone has COVID, you can't use this product. This product is for prevention only, not for treatment. And they really limit it for those who are having moderate to severe immunocompromise. So what is that? I mean, there is generally a list, and I'll share later the list. I don't know if it's coming up soon, but it obviously solid organ transplant recipients are squarely into that list. These are the considerations. It is sort of an IV injection. It's not intramuscular the way Evusheld was. And so you have to infuse over more than an hour or about an hour, and then you have to observe for at least 2 hours following administration, because there were some infusion-related reactions and hypersensitivity reactions. About 4% of those patients had that. And cumulatively between all the studies, in particular with people who got 2 doses, it was about almost 10% of people. And and some of those did have anaphylaxis. So this is not necessarily a benign drug. People did have some serious side effects to this. But overall, as you can imagine, on balance, preventing severe COVID and maybe a 4 to 9% risk of a hypersensitivity reaction, that generally went away. The balance favored giving the medication. Maybe not for everyone, but certainly for those who are at extreme risk or immunocompromised. The other thing that's important is the authorization was for this to be given every 3 months. They don't have data on how much longer lasting the drug is. So really, you would have to do this every 3 months. And, certain differences between Evusheld and this, Evusheld was free, right? The government paid for it. There was never any consideration of insurance and costs or any of that. Pemivibart is not, it was the government, is no longer covering these medications, as many of you know. So there was enormous sort of uncertainty about would insurances cover this, and how much would patients be on the hook for. So those were some questions. And then availability, I'll tell you, for our own experience, we've been struggling getting a supply. We have everything ready in terms of the logistics and the room and the infusion center is ready, but it's just there hasn't been any availability in our center, which is surprising to me, quite honestly. I know that other infusion centers have had it. I keep hammering at our pharmacists when we're going to get it, but the matter of the fact is we haven't. And I don't know if it's the complexity of having like Weill Cornell and Columbia. Unfortunately, we haven't had it, and I just checked today. But this is what's really interesting about the pemivibart is the Transplant Society, we met about a month ago or maybe 2 months ago. It was right before like people went away on summer vacations, and talked about who should we give this to, given that it's a 3-hour infusion basically. Maybe there's some costs associated, and the data are not as robust, right? Basically, we have just basically this immunobridging data. We don't, and maybe some unpublished stuff, right? That maybe less patients got infected or were symptomatic, but it never fell to the transplant community enough robust evidence to say we need to give this to everybody. So, we met a few times to talk about, well, we should still give it to people, but who should be prioritized? And as the American Society of Transplantation, the basic recommendation was we need to give it to those who are at highest risk of severe infection. If they get COVID, they really are in a bind, right? So lung transplant recipients were squarely into that category, or someone who recently got treated for rejection, whether they got thymoglobulin or high-dose steroids or something like that, that would put them at a greater risk, or someone with underlying lung disease, right? Even if you got a kidney transplant, if you have COPD, or you have sort of vulnerability to a respiratory viral infection, you probably should be prioritized for this. And then the second group is those who were least likely to respond to a vaccine. No matter how many shots you get, you're just not going to respond. And there are certain medications that do that to you. Rituximab is one of them. So that's what we basically said: lung transplants, underlying lung disease, and then rituximab. And what's really interesting, in some ways satisfying, right? So 2 days ago, the Infectious Disease Society of America released their guidelines for the use of pemivibart. And actually, it's good to know, because some of these are my colleagues that I can go back and ask them. In fact, there's someone here who works in my institution. I work with her almost every day, and I didn't have time to go ask her today about this. But in general, this was wonderfully written. And the main recommendation from this guideline from 2 days ago is the following, right? In moderately to severely immunocompromised individuals at risk for progression to severe COVID, the IDSA guideline panel suggests pre-exposure prophylaxis with pemivibart when the predominant regional variants are susceptible to the agent. Okay, so they're putting their caveat there, smartly so. And this is a conditional recommendation. I think it's conditional based on more data, with low certainty of evidence, because again, we don't have as much data. And here they go into making some additional remarks. The anticipated benefit is likely greatest in people who are most immunocompromised, because they have the higher risk of inadequate immune response and progression to severe disease. And I'm going to show you table 1 because of the examples. In fact, actually, for teenagers, the anticipated benefit is lower. I don't know exactly, the reasons for that. But as evidence is based on immunobridging and circulating variant susceptibility is evolving, additional clinical and laboratory data may impact this recommendation. We talked about how subvariants keep changing, and there has been some significant changes recently. So they smartly added that bullet. And then there's sort of discussions about patients who place a higher value on potential harms, right? In particular, sort of this 0.6% risk of anaphylaxis and these other reactions. Well, it's warrants a discussion. It shouldn't be a blanket recommendation to give this particular medication. Okay. So here are sort of the broad categorizations in terms of high, moderate, and low risk of immunocompromise, right, patients. So here you have sort of an example types of patients. So stem cell transplant recipients within 2 years, in particular, allogeneic stem cell transplants. Those who are experiencing complications of stem cell transplant, this is graft versus host disease. It can be a pretty bad thing. Anyone with like leukemia, for example, should probably consider getting pemivibart, and then lung transplant recipients. And then the other major issue is this sort of rituximab, right? So here's rituximab as a B-cell depleting agent that basically you're incapable of forming antibodies, no matter how many vaccine doses you get. And then the moderate category are all the other solid organ transplant recipients. And here you can see sort of the rest of the patient population: cirrhosis and end-stage renal disease, IBD, and then solid cancers and so forth are in the lower risk of complications. Regarding sort of these variants and pemivibart, right? So right after the American Transplant Congress, they were able to actually nicely release this data that pemivibart actually did retain activity against KP2 and KP3, which is really great, because back in June, those were sort of the main variants. And that data was sort of corroborated by a bunch of investigators. So pemivibart was very reassuring. You had activity against JN1 and then KP2 and KP3. The issue has been, and as many of you now know, yesterday, David Ho from Columbia, sort of this paper came out as a preprint. And many of you know him, and we've had discussed his papers on numerous occasions in the last several years. He has a tremendous lab at Columbia. He is an original sort of HIV investigator, but when it came during COVID, he basically geared his entire lab towards SARS-CoV-2, in particular looking at monoclonal antibodies and vaccine responses. So he really has this down to an art or to a science, I don't know, whichever one you want, but he really knows what he's doing in looking at products like monoclonal antibodies and vaccines, in particular the antibodies that vaccines form, and see how how they perform against all the variants, right? So as many of you can see by the title, that's a little bit of an ominous paper, right? It's less active against the more recent SARS-CoV-2 sublineages. So I think you've seen some of this. I certainly have presented these curves before. Essentially is sort of the percent neutralization of the product based on the concentration, right? So a lot of things, if you really kind of basically have super high concentrations, most products will work. But the problem is that, some of those concentrations are not achievable in the body or are actually toxic in the body. So these curves are a little bit misleading because it's sort of what is the normal value that one would expect in terms of the concentration of the monoclonal antibodies, and then looking at its ability to actually neutralize the subvariants. What you can get out of this here is that anything to the left is good. It actually requires very little concentration to neutralize. Anything to the right here, sort of taking a while to go up, is not so good. It's sort of its ability to neutralize is slow. And here you can see in orange, KP3 1.1, unfortunately, is in that latter category. And here is a little bit easier to interpret, whereas JN1, which is sort of the index or the reference sublineage, this is sort of its activity with each variant or subvariant, KP2, KP3, KP2.3, which we haven't really talked about. It's not that important right now, maybe later. And then KP.3.1.1, you can see that now sort of the fold increase, sort of, its relative resistance is 30 times higher than J81. 30 times higher is a big deal. Basically, the monoclonal antibody is almost inactive against that particular subvariant. Again, this is in vitro, but that is sort of a bad result, whereas interestingly, LB.1, right, LB1, which is still a circulating virus, and actually I have here, I put this back here, I showed this to you early. So see how this stacks, right? So right now, the predominant subvariant is KP3.1.1, which basically Pemgarda has no activity against. But there is about a quarter of the variant, the case is that it is LB1, which it does have activity. It does have activity against KP2.3, KP3 as well. So if you were to add these up, right, sort of it's about 50% of the variants, if not more, because these, these were not studied, but could be that these are active as well. It's probably right now, or as of last week, it's about 60% active. Or let's put it this way, Pemgarda is active against probably about 60% of the circulating virus. And maybe there's about 30 to 40% that is not. It's a little bit of a tricky situation, right? It's very dynamic. And what is predicted, unfortunately, is that KP3.1.1 is sort of soon to be much more prevalent, right? 50%. And so I think what we're seeing is that, the utility of Pemgarda might unfortunately be going down. When I asked him this afternoon, he says, yeah, ominous indeed, we have to stay vigilant and keep track of these subvariants, but if it's KP3.1.1, it's not clear that the product is useful. And here he says in the text, our findings show a substantial loss of Pemgarda activity against this particular subvariant, the most rapidly expanding SARS-CoV-2 subvariant, not only in New York, but in the country. Therefore, close monitoring of the clinical efficacy of this new authorized monoclonal antibody is warranted. What he's trying to say here is that he could still be wrong, right? Like this is a lab finding showing that in lab it's not active, but clinically maybe is. He doesn't have a track record of being wrong, or not him necessarily being wrong, but the data not predicting incorrectly. Unfortunately, his data and others in other labs have been quite on point when it comes to the variants in these monoclonal antibodies. So it's alarming, for sure, very deflating, for sure. Just when we're all gearing up to give this, you sort of have this sort of a little bit of a bombshell news. So where to take from here is unclear, right? I think we have to see what happens. I still think my recommendation today to my institution was we still need to go forward and have every preparation to have this up and running, because we don't know and we should give it a chance, and monitor it. If more data come from other labs that it truly is not that active, and people who have gotten pemivibart still get COVID, and are severe, then I think our answer will be there. So I think that's essentially what we're going to be talking about monoclonals. This is a very small sort of word on the new Evusheld or Evusheld 2.0. We talked a lot about it last year. It's still in phase 3. They are now calling it sipavibart. They did meet their primary endpoints, and they submitted to the FDA authorization. But interestingly, it hasn't been authorized yet. It's been sort of sitting there for about a month or 6 weeks. So I'm not sure what is happening. Or maybe we'll hear about it either tonight or tomorrow, that is certainly authorized as well. I don't know, but it's certainly sort of strange that there's been no word about it. Regarding therapies, and I know it's already 9 o'clock, there's been no change. Our 3 main drugs are remdesivir, which I would put in the top of my list. If I had COVID and I had a way to get it, I would get that. Paxlovid, we've talked about it. It's effective, but complicated in a transplant recipient because of significant drug-drug interactions. So you really have to coordinate very closely with your transplant providers about tacrolimus in particular. And then monopiravir. Monopiravir is the less active of all the other drugs. Long COVID, this is just a paper that I reviewed for HAT a few months back, and it's now published. Really great work from this group, including Rosalind Mannon and Mike Eisen, probably people that you'll recognize. They actually did find that transplant recipients do have higher rates of long COVID. This is a very sort of, 10,000 feet sort of picture. It just basically says that people have more long COVID. It's not clear what kind of symptoms and what's driving, but some risk factors besides, having COVID and being a transplant recipient is older age, use of mycophenolate, and the severity. Sort of the more severe COVID, the higher likelihood you are to have COVID. Now, what's also important is that the vaccine, sorry, and I guess I put this quotation right here, vaccines do prevent or have a big role in attenuating long COVID. And that has been shown over and over again. So it's really important for those not to be discouraged about the vaccine, because it can have, even if you have COVID, it can diminish your risk of long COVID. Now, someone wanted to talk about the sort of multisystem inflammatory syndrome in children, or MIS-C, which is, in a nutshell, it's a severe inflammatory syndrome that it only happened in children who have had COVID-19. It was described actually early on, and actually maybe, it's sort of infamy or good or bad, I'm not sure, but it was described at Columbia by a number of pediatricians in our center, including Phil Zachariah and other people that I know well. Basically, we're noting these kids who had COVID a few weeks before coming in with fever, rash, in severe shock, maybe headaches, neurocognitive decline, and as well as cardiac dysfunction like myocarditis and heart failure. Very alarming. And for the last 4 years or so, people have been trying to figure out why that happens, suspecting it was an autoimmune disease or some sort of issue that COVID triggered. But you probably heard in the news last week that actually there is this really important paper that just got published that kind of basically figured out. I don't have even the knowledge to go through it all. This is extremely basic science and immunology. But basically, they knew that patients with this MIS-C have a distinct set of autoreactivity, meaning like they had an autoimmune disease. And they really knew that both B and T cells were dysfunctional and driving that autoimmunity. And through a number of analyses and sort of they studied a cohort and looking at their blood cells and antibodies and T cells, basically discovered that in about a third of the cases, if not more, the immune system was targeting this protein, SNX8, which is sort of an innocuous protein. It doesn't do much, it's sort of randomly, but it is sort of widely expressed in the body, especially in immune cells. So in some ways, it was explained sort of why there was this autoimmunity all over the body, and people will have sort of different types of presentations. What was also interesting, and they were able to show, is that this protein, unfortunately, is sort of has a very similar appearance to a nucleoprotein for SARS-CoV-2. So basically, as the immune system was fighting SARS-CoV-2, it developed antibodies and T cells against that SARS-CoV-2 nucleoprotein. And then later, those cells and antibodies somehow got their attention diverted to this protein and start attacking the cells with this protein, which is essentially what autoimmune disease is. I mean, what's exciting about this is that you can now develop potential therapies against antibodies for this protein, probably monoclonal antibodies. And children who may be developing this disease can be actually treated very effectively. So it's a wonderful unlocking of a mystery. And I think it's going to open up a number of venues in terms of this. But it also shows that a number of infections can be triggers to autoimmune disease, which is really interesting. Last few minutes, other viruses, the flu shot, obviously, we're all going to get our flu shot in the fall. What's going to be interesting or different this year than last few years, this is going to be a trivalent vaccine, not a quadrivalent vaccine. Now, it's not a big deal, right? Basically, what they were tracking in the Southern Hemisphere is there's only 3 lineages that are important at this time, H1N1, H3N2, and this B Victoria lineage, the viruses. There isn't a 4th one, so there was no need to create a quadrivalent, right? You don't need that 4th valent, that 4th virus, if it's not going to be a predominant issue. So not that big of a deal, that's trivalent versus quadrivalent, unless there is a 4th type of virus, and then they will have been proven wrong. But that in itself does not make the vaccine weaker. What's going to come up, and I'm going to publish this in about a month, is that for solid organ transplant recipients age 18 to 64, they are now recommending either the high dose trivalent vaccine or the adjuvanted trivalent vaccine. So those are accepted, whereas previously it was always just the high dose vaccine that was recommended. Now they're also going to recommend the adjuvanted vaccine. It's called FluAd. So I think what's going to happen is, because the adjuvanted vaccine is also recommended for other age groups, in particular those over age 65, basically they're just going to have that one vaccine and be available. For all practical purposes, it doesn't really matter, but it's just going to be sort of maybe a little bit more of a streamlined recommendation for this fall. RSV vaccine, we talked last winter about it. And my recommendation last year was, unless you're a lung transplant recipient, let's wait and see on more data. We're still waiting and seeing on more data. But the other issue that came last year was that even the CDC was also, let's wait and see for more data, because they were very wishy-washy in their recommendation last year. Basically, they used the language shared clinical decision-making. And that was code word for, like, we're not going to strongly recommend it. You talk to your provider, and providers talk to your patients and see what you guys decide based on your concern for RSV. Now they're making a little bit of stronger recommendation. So all adults over 75 years of age should get the vaccine, and all adults aged 60 to 74 who are at increased risk of severe RSV disease. And that's basically people with chronic medical illnesses, in particular lung disease. Does this imply solid organ transplant recipients? Not necessarily. I think that we still have to look a little bit more for that. So I don't think that we're going to give a blanket recommendation or a strong recommendation for every transplant recipient, but certainly if anyone has any inkling of a lung disease, and definitely lung transplant recipients should get the RSV vaccine. Pfizer also 2 days ago, released this top-line result for their immunocompromised study on RSV vaccine, which does include patients with lung cancer, those on hemodialysis, those with autoimmune diseases, and transplant recipients. Basically, what they found is that it was very immunogenic and very safe. This is going to be an important result, and I think that we're waiting the actual clinical study results to make more decisions, but it's all encouraging. So I'm becoming a little bit more supportive of the RSV vaccine for the population. And then the last thing, a lot has happened this week. Yesterday, the WHO declared Mpox a global outbreak, or an outbreak of international concern. So Mpox is back in the news. And essentially what's been happening is that there's this low-level Mpox in the United States that's largely driven through sort of, men who have sex with men. It didn't spill over into a broader population, but it's been very contained. That population did an enormously great job of getting vaccinated, protecting themselves, and really curbing what could have been a disastrous outbreak. And now it's sort of really occasional cases that we see. So it feels like it's been very well contained in the United States and in Europe. What has been happening in the Democratic Republic of Congo, however, is that they have had, historically higher levels of Mpox, and it's been largely driven from exposure to animals. So it's a different sort of epidemiology there. But what has happened in the last year or so is this rapid spread of a different kind of Mpox virus, this clade 1b, that actually is also spreading through sex, but it's spreading through sex, like heterosexual sex. It's not just certain groups, but also it's spreading to children. So like daycares and schools and things like that. So it's a little bit of a more tenuous situation, and it's also spilled over into nearby countries. The other concerning thing is that tecovirimat, which is an antiviral medication that we're using in the US for our clade, which is clade 2. There was a study that I don't know the details on the study design, but it didn't work. So I think people are scrambling a little bit about Mpox right now, and it's no reason to panic, but certainly a reason to keep a very close eye on what's happening with this virus. We did have cases of transplant recipients with Mpox. Most of them did quite well, some not so much. So it is sort of something to keep an eye on and really track. Okay, so that's sort of the the note of doom that I have at the end. But overall, we're in okay shape. So let me stop sharing and see what kind of questions we have, and I'm happy to spend maybe like we can do like 10-15 minutes. Maybe we'll close at 9:30 answering questions.
Thank you so much, Dr. Pereira. As always, really, really informative. I think you've given us a lot to digest, think about, spending your time with us. Really appreciate it. I think I speak for all of us when I say that. So helpful giving us the advice and hints to protect ourselves moving forward into the fall and to continue the rest of our summer on what to look out for and
Yeah.
decisions to consider and think about with Pemgarda and how to protect ourselves with the vaccines moving forward. So we really appreciate you giving up your Thursday evening and stuff like that.
My pleasure.
Ira and Glenda, I know you guys have been watching the chat. So
Yes,
if you want to read some of
sure.
the questions that came forward in the chat for Dr. Pereira, that would be a huge help.
As usual, Dr. Pereira, there weren't that many questions because the way you present things, it really kind of puts into perspective what's the important stuff we ought to all be hearing about. But we did get a question from Laura that said that if you are about RSV, if you are in the high risk group, like lung patients, and you got the RSV last year, should you again go and procure the RSV again this year? Is it the typical kind of get yourself vaccinated every year for RSV?
Laura, that's a wonderful question. We're all wondering the same thing. That there is no recommendation for getting a second shot. Right now, it's sort of the Pfizer vaccine, both of them are like one dose only. So there's no recommendation, but that's what people are studying, right? So this Pfizer study, for example, are basically it's 1 versus 2 doses. And I didn't talk about it, but they basically showed that the immunogenicity provided by 1 dose was so high that they don't predict that patients will need, or solid organ transplant recipients will require a 2nd dose. But I think we need to see this a little bit more sort of over time about that. So more to come. And I think that the transplant community is very interested in studying this longitudinally, much like what we learned from COVID, right? So what happens with your monoclonal antibodies or T cells a year later, 2 years later? So that's a great question.
You gave us some recommendations in the past. If you are one of those patients who received your vaccines pre-transplant, what should be your schedule for vaccines post-transplant?
Great question. So we have previously, if you got something like thymoglobulin, right, like kidney transplants received that, in general, we do recommend getting a booster dose within a few months. Not immediately, but within a few months, only because, you know, you probably lost a lot of immunity there. But, you know, for most transplant recipients, you probably should get it within 6 months, another booster dose. Especially if you only got steroids, for example, liver transplant recipients only get sort of a high dose steroids, right, as your induction immunosuppression. You can probably get away with like 6 months of getting a booster dose.
Okay. And again, I believe you've given us some recommendations in the past about should the family members of transplant recipients get all the boosters as part of
Absolutely.
it? Okay,
Absolutely. Absolutely. You want to create this protective ring, right?
great.
Someone here had a good question. What was, oh, the timing. If you do get Pemgarda, how long do you have to wait for the vaccine? In general, it's extrapolating from the Evusheld recommendations. It was 2 weeks. You want to sort of give some time, you know, and then get that. But you know, the good sequence is really getting the vaccine first, and then waiting about 2 weeks and getting the monoclonal antibody.
Okay. There's a question also about if you've been on IVIG and its relationship then to using Pemgarda.
Wow, that's another great question. I don't know the answer, quite honestly. I don't know if there is a concern there. I mean, obviously, both they're very similar. They're similar products in the sense they are antibodies, right? IVIG is pooled antibodies, right? So you get like a number of donors when people donate blood, and you can separate antibodies from the rest of the blood and sort of reserve it as IVIG. So it has antibodies against dozens of viruses, if not hundreds of viruses, CMV being one of them, and probably by now plenty of SARS-CoV-2 antibodies. It's just not as concentrated as Pemgarda, but there shouldn't be any reactions to it. I don't think I saw anything about IVIG and Pemgarda sort of as a contraindication or something to think about the timing. You probably don't want to get it too soon because they both have sort of the risk of reactions, right? IVIG does too. So you probably don't want to get it too soon in between them, but I don't think that there's a contraindication. I'll have to look that up, quite honestly.
Did you specifically give us a vaccine recommendation for the lung transplant recipient, particularly if they're in rejection?
I didn't, but so if someone has rejection, it really depends on what they're treated, right? So a lot of lung transplants with rejection get maybe a bolus of steroids. That shouldn't necessarily prompt sort of an earlier booster vaccine more than whatever you were planning on getting. So that shouldn't change. But if you do get sort of heavy immunosuppression, again, thymoglobulin, you probably do want to get a booster probably within a month or two.
Okay. Does immunity last shorter after COVID infections for transplant patients? I'm not-
Unclear. I think there's a sense that yes, but also that the immunity that is formed is not as strong. And again, I think it's the same issue regarding the response to the vaccine, right? Sort of immunocompromised patients don't respond to the vaccine as well as someone with an intact immune system. So when you recover from COVID, that immune response is probably not as robust. Now, it could be in terms of its strength, but also duration.
Right. Is long COVID, is an individual with indications of long COVID continue to be contagious?
No, that's a good question, and the answer is no. Long COVID has to do more with, I mean, it's still mysterious to us, but it's not thought to be ongoing viral replication. Long COVID is generally sort of a dysfunctional, what we think is a dysfunctional set of responses to an infection. Maybe autoimmune, maybe inflammatory, maybe it's more nuanced than that in ways that I don't know. But it's a set of symptoms, right? Fatigue, lack of concentration, poor sleep, poor energy, aches, sometimes fevers. But it's not sort of a situation where we think there's ongoing viral replication and therefore people are infectious.
So it's bodily functions that have been compromised by you getting the initial COVID.
I'm sorry, say that again?
So body activity or functions that have been compromised by the disease.
Yeah, we
Getting-
think that's the thing. I mean, I don't think there has been a breakthrough for long COVID as there was for the MISC. So we still don't understand. But it could be that it's all part of the same spectrum, right? I mean, I think that's going to be interesting. People are, I'm sure, going to look at this protein for those who have developed long COVID and see are adults having a more attenuated autoimmune response to that protein in particular, leading to the same, it's all a spectrum, right? Sort of having fevers, fatigue, muscle aches. Obviously children were having an enormously dramatic response or serious response. And maybe long COVID is the same. I mean, I'm just conjecturing right now, but this was actually a really interesting finding that you can now sort of target and look at and see, like, are people with long COVID also having antibodies against that protein and maybe other proteins? Milton, not really, right? We have not developed any, and it's definitely a big gap in research and care in COVID. There are many gaps, but long COVID is one. I have a colleague who studies long COVID at Columbia, and I'll tell you, every day is sort of a confusing day for that person. They're trying to get a lot of data, and they don't really know what is real, what is not, and following all the sort of trends. And certainly there are no sort of best treatments. Now, the prevention, I think there are some good data now that the vaccine can help prevent symptoms of long COVID. How do you know? Well, it's one of those things. There are a list of symptoms, and you have to have those symptoms at least for a month, and you can't have active COVID. You can Google it. There's the CDC, I think, has a really good website on long COVID, or the NIH does. And you will see it's a long list, the list of symptoms. And it tells you that, people don't really know because it's sort of a very broadly defined syndrome right now.
There is a question about comparing the efficacy of RSV vaccines. You have
Yeah, Janet, I don't know that data. I only saw what came my way was that Pfizer study with the immunogenicity. So just a quick word, there are two vaccines for RSV, right? There's the Pfizer one, which is actually a bivalent vaccine. So it has two little strains of RSV, and the GSK is adjuvanted. So, the adjuvant is basically there's a compound added to the vaccine that can enhance the immune response. Last year, we had no idea which one. There's a lot of discussion about this. Which vaccine do we think is going to be better? The studies in the general population were basically, I think, the same. They're sort of the same level of response. So I don't know, I will have to look at this particular study because the phase 3 studies basically showed the same level of response. Now, for transplant recipients, we were all wondering, maybe one of them was going to be better than the other, and what particular feature of the vaccine was going to be more useful for transplant recipients. And I have to say, there was a lot of chatter about maybe the one that's adjuvanted, because it will have a higher level. It's going to induce a higher level of immune response to the vaccine. So that's what we're really curious about. JSK does have a study for transplant recipients as well, so we're kind of eager to see that. And I don't know if that's the study
Yeah.
that you're referring to.
The study that I'm referring to was done by Johns Hopkins, by Bill Warble's team. So I think it was published under Andrew Caraba was probably the lead
I
person.
can't remember. But this is basically just on antibodies.
No, it was. I mean, I don't remember the specifics of it, but I know they presented it at AST, and it surprised me in looking at how far superior the GSK vaccine was to Pfizer, and then I realized, and I had heard that, and I tried to get the GSK one, but it wasn't available, at the time. So, but it's just something to make people aware of, and I guess people have to do their own research, or we have to talk about it at the next one when everybody's had a chance to look at it.
Yeah, I know Andrew, he's a superb scientist. We talked a lot during ATC. So I will check out. I know that he is a excellent researcher. So I'll take a look. I know that he's done a bunch of, obviously, COVID vaccine studies and presented during ATC as well. But I'll check with the two of them. I mean, Will is also wonderful.
Okay.
I don't think right now we have very strong data, and if they did, this is all going to be preliminary. So I don't think anyone is ready yet for making a strong recommendation of one over the other.
Okay. Thank you.
Sam, I saw you had your hand up before.
Oh, I was going to ask the question about RSV, and then when I realized what that Ira was reading from the chat, I thought, well, I'm just going to take my hand down and type it into the chat, and that worked.
Yeah, hi, Dr. Pereira. I also typed it in the chat, but basically, the adjuncted flu vaccine you recommended or will be in the paper. Will that be available at the pharmacies, or will they question it?
I believe so, because I think that these recommendations generally are so strong, right, coming from the CDC, that most pharmacies and insurance companies just follow it. So it should be available.
Okay, and one more comment. You're looking younger. Maybe it's your hairstyle.
Thank you.
Oh, actually, there is one thing I would like to just tell people about Pemgarda. Our group TRAPAG met with ASPR, which is HHS Administration for Strategic Response and Preparedness, and Medicare to talk about Pemgarda coverage. So it's covered, as everybody knows, for no copay with traditional Medicare. The wrinkle right now is Medicare Advantage. And so we made a strong case to them about, and the person that from Medicare that was on the call was the person that was in charge of minority equity, I guess. Great. And so we made the case about financial inequity of not being able to get this medication if you couldn't afford to, do the copay or out of pocket. People that are not yet of Medicare age, what we are learning from people in our group is that, people, this is, I guess, Blue Cross Blue Shield and also United Healthcare, you have to meet your out of pocket. And so one person I talked to who's in New York, her husband gets rituximab 4 times a year. And so the out of pocket for, or I guess they get billed for the first rituximab. The bill comes in at $17,000, but their total out of pocket with their in policy is $6,500. So they budget for that amount every year. They just know they've got to, be able to do that. So then Pemgarda was covered for them 100%. And one thing I will mention, just in terms of people that are trying to get Pemgarda in the New York area, if you happen to have Medicare, traditional Medicare, Prime Infusions is able to get it for you. If you have a prescription from your doctor, they can do that. And then also operating in Connecticut is Local Infusions. And they actually have a medical, I think it's a nurse practitioner, but someone who can write the script for you if your doctor sends the records. And they do a crackerjack job of reaching out to the insurance company and finding out, what your costs would be. So there's ways to get to we at least know some of the paths in the city.
That's incredibly helpful. Yeah, Jen had mentioned Prime. I did not know about them, but this might be a really great solution because the hospital infusion suites are constantly booked, right, for people getting Aticept and rituximab and those things, and that was going to be a big stress. But I'm going to pass that information along to all my transplant providers, because if they can then write the prescription, connect with Prime, that solves numerous problems.
I can connect you. I'll send you an email, Marcus.
Please do, and I'll send it their way. Yeah.
With there are two people at Prime that we work with. One is the pharmacist, and then they also work with an oncology practice that has a provider that can make the specific request. I mean, I know that that's how they like to do it. I think they get paid more for doing that. But what I ended up doing is just sending all of my records, and then my doctor sent the script, but I think that they filed another script. I'm not sure exactly how it works out.
Yeah.
But
Jen, you might have told me about, I think you sent me some information about Prime, but yeah, send my way too, Janet, so that I can distribute it to my transplant providers. I think Jen was also, you two were on the same trail. I mean,
exactly.
The Pemgarda website, if you look at, available, if you type in sort of, it doesn't show anywhere in the Northeast. Like even Pemgarda website is not able to track down in this region.
Right.
Not California either.
Yeah.
The other thing I just did want to mention is our group TRAPAG is also we're in close communication with Invivyd's senior and executive management. So we've been basically, in fact, while we're on this call, I set off an email. This is what I'm hearing from Dr. Pereira at Columbia. So this makes no sense to me. So we'll see what they come back and say.
Oh. Am I in trouble? Am I going to get a call from them?
No, I mean, I think that if you're hearing from the pharmacist, we can't get any supply. I mean, there's some disconnect because what they tell us is it's available with the distributors, the major drug distributors. So it's a drop ship from a drug distributor.
I don't know what's been going on in New York Presbyterian, quite honestly, and maybe somebody in New York Presbyterian dropped the ball. I've been asking, and I have some trusted pharmacists there, people that have been working with decades, who generally get the job done, and they have said, it's not coming in, and we don't know why.
Yeah,
I'm gonna guess, Janet, it's something specific to New York Presbyterian, and I don't know why. Maybe it's just too complex, and there's a snag somewhere that nobody has been able to figure it out.
Yeah,
that's probably what they're gonna say, but it'll be good to know, right?
I think this all goes back to the frustration of patients, and I will say this, I speak for all of us, I think, and I'm sure many people will back me up on this call, to the vaccines. When the pandemic started, there was just a disconnect on communication, and we were all very frustrated, and we all felt left out in the dark.
Yeah.
where do we turn to, you know, what's safe, what's not safe, should we be vaxxed, shouldn't we be vaxxed, you know, is this putting our organs in jeopardy, you know, where's the communication to the patients from the transplant centers? And we all felt left out in the dark, right? And I think that's how we feel now, you know, hearing this about Pemgarda and stuff like that. So it's just, you know, it can be very frustrating, right? So that's why we're so appreciative of you, Dr. Pereira, giving up, you know, a Thursday night to talk to us and to point us in the right direction, you know, with the vaccines, with influenza, you know, for the fall and what to do. So again, you know, and also Janet, thank you, you know, for giving us the tips, you know, moving forward with the prime infusion, you know, and now, you know, the local infusion, you know, basis in Connecticut. Really appreciative to you for pointing this out, and you know, the TRIPEG committee, and Steve also. I know you're really devoted to doing this, and you guys giving up your time and energy, you know, to fight for the patient rights, and everything like that. And for everyone else who's an advocate, you know, to get the word out and the importance of organ donation and everything that you guys all do to give back for everything, for your gift of life that you guys have all received. Really appreciate everything that everyone does, right? Because I know we're all grateful recipients. And for those that are on this call that are still waiting, you know, for your opportunities to come forward, I just want to thank all of you guys and for participating tonight. And again, Dr. Pereira, thank you for giving us, you know, the insights and the ins and outs. We always really appreciate you coming here and filling our heads with more information. We're really appreciate it. So I just wanted to say thanks. And if anyone else, you know, has any more questions, feel free to reach out to me, and I will pass on the questions to Dr. Pereira, and get the questions answered for you guys. And I'm happy to do what I can to, you know, do the go-betweens and stuff like that. So, any other questions for Dr. Pereira before we end the evening? I don't want to keep him too late because he's got an early day, I'm sure,
Yeah,
tomorrow
I
morning.
think I gotta
Big
go,
round of
actually.
applause from everyone.
I do want to just add one additional point about what we asked Medicare for, which is what we're, you know, for Medicare Advantage patients. There's a very clear statement that it's going to be covered 100% like a vaccine for Medicare Advantage patients. That's what we've asked them to rule on and to put on their website. So, you know, I will, we expect to hear from them in the next week or two. So I will circle back when we get that information. So thanks again. And thanks for organizing this, Jen. And thanks, Dr. Pereira.
Yeah,
Have a good night,
absolutely.
everyone.
Absolutely. It was my pleasure. Thank you guys all for joining. And this will be posted, I promise, to YouTube eventually.
Thanks so very much.
All right. Good night.
All right. Take care. Thanks again, guys.
Thank you.
Good night.
Appreciate
thank
it.
you.
Thank
Stay
you.
safe.
Everyone.
Stay safe. Wear a
Bye,
mask.
guys.